Thank you. And I thought, although a lot has been said about the outstanding attributes of this very great human being, Dr. C.V. Krishna Swami, but I thought I'll start my oration by paying my tributes and salute him for what I consider his being a great physician and an outstanding human being. And I'm honored to be delivering this oration in his memory. I must thank the scientific committee of 3DCon for honoring me with this oration and allowing me to share some of my thoughts on this topic on an area of research which I've been doing for the last 2 decades or more. And as we go along, you will realize some of the facets of this research, actually the world is now converging onto that, and probably we'll hear more and more of this in our day-to-day management in the decade to come. Triglycerides to treat or not to treat is, I think, one of the most common clinical dilemmas for all of us, particularly those who are managing patients with diabetes. Partly because we are all aware that, triglycerides are associated with a lot of cardiovascular risk. But at the same time, unlike LDL reduction, TG reduction has not resulted in long-term tangible cardiovascular benefits. And that's the dilemma. So we'll examine during the course of this oration, through some of the traditional and some of the novel perspectives, some of the questions which I think this topic tends to address. So what we'll do actually is, why should we treat triglycerides? We'll try to answer that. Are we targeting triglycerides correctly? Should we be looking at fasting or postprandial triglycerides? Is another question we'll try to answer. What is the new information and novel approaches available from recent research? And should we treat triglycerides to reduce diabetes risk? This is another new dimension which is part of my research, and we'll talk about that. Energy handling and postprandial triglycerides is an important area which we are now converging into. And can we reduce postprandial triglycerides through intensive lifestyle approaches and bariatric surgery, you heard? And can we achieve remission in diabetes? And is there a role of triglycerides there as well? And then we'll conclude. These traditional things we're all aware. This meta-analysis actually shows that both in women and men there is a significant cardiovascular risk with hypertriglyceridemia. And we also know that highest tertiles or quartiles of triglycerides are associated with significant cardiovascular risk. We also know that triglycerides drives LDL to form small dense particles. Again, all of us are aware that these are important atherogenic particles, more than the LDL itself. And hence, coming to the question of triglyceride lowering and severe risk reduction, while this is established that the risk exists, it's unclear whether reducing these levels actually effectively lower such events. A recent study involving high-dose supplementation of omega-3 fatty acids indicated no reduction in cardiovascular events despite 20% drop in triglycerides. Also, earlier trials which we are all familiar with, the field aim high for HDL, which also had TG reduction, and ACCORD, where TG levels actually dropped more than 25%, again failed to demonstrate any significant reduction in cardiovascular events. So there is a paradox. These are the trials which we're all aware, which actually show on the right side of this table that there's no severe risk reduction. However, subgroup analysis and post-hoc analysis, both in the field and the ACCORD, suggested that patients with high triglyceride levels and low HDLs, especially those with type 2 diabetes, could benefit and could have significant cardiovascular benefit. This was some analysis which was not part of the main study, but a follow-up analysis. As can be seen by giving PPR alpha agonists, that is the fibrates, you can very clearly see that, especially in those in which the TGs were more, there's a left panel, you have significant benefit demonstrated. The diamond is to the left of the main central line. Whereas if the triglycerides are less than 200 and HDL is more than 34, the benefits do not accrue in terms of cardiovascular risk reduction. So that was a sub-analysis, which was published in Diabetes Care. It was also shown that in diabetic patients, you could have, by reducing triglyceride levels, reduction in macro as well as microvascular complications. So there is still a case, despite the other data, to suggest that you might be missing something and probably TG reduction is beneficial. To examine this very recent study with pemafibrate, the latest drug in the same family, through the prominent trial, aimed to evaluate the use of this drug in patients with diabetes with elevated TGs more than 200 and HDL and less than 500, and also a low HDL less than 40, in a randomized double-blind manner. And what did they find? Despite lowering triglyceride levels, VLDL, remnant cholesterol, ApoC3, and so on, the incidence of CV events was no lower in those who received pemafibrate compared to those who received. So this did not find. So that subgroup analysis, which triggered this study, was not borne out by the results of this particular RCT. Another study, again in NEGM recently in 2019, a multi-center randomized controlled placebo-controlled study. This is basically by icosapent related to the omega-3 fatty acids derived from there. Try to look at whether this can be beneficial in the same subgroup of TGs, which we normally don't treat. 130 to 399 is what this, 499 is what they studied. Here they found significant clinical benefit, as you can see from the panel. However, this was not related to baseline TG levels or on treatment TG levels. So benefit may have been due to something else, not necessarily TG reduction. So we are in a fix. Despite knowing all this information, despite the latest trials, and despite some suggestion in between that they could be working, we do not have trials to support clearly their use. What could be the reason? Why has this not translated to a reduction in CV risk? Has this been because we're focusing at the wrong time? Should we be focusing on PPTGs? Because it's been shown that even in patients who have normal fasting TGs, their postprandial triglycerides are elevated in many of them. And it's also been shown through several studies that PPTG is an independent risk factor for cardiovascular disease. This has been there for the last 2-3 decades, and even we have shown in some of our studies. So is it that we are failing to achieve the desired benefit because we are only focusing on fasting triglycerides? That's the question. And this was the study which inspired me to do my research over the last 20 years in this area of postprandial triglycerides. This was a study by Patch, which actually showed that by multivariate analysis, PPTG levels have a statistically independent and stronger association with CAD than HDL cholesterol, which we believed always was the strongest risk factor for coronary artery disease. We also know from metabolism that triglyceride metabolism is critical determinant, and especially the postprandial triglyceride metabolism is a critical determinant for cholesterol routing. I told you about small dense cholesterol and how the particle size changes and how things are routed. And therefore, could it be that the postprandial triglycerides are the things to be looked at? With that in mind, especially in diabetic individuals, we proceeded to look at whether we are finding in Indian patients postprandial triglycerides at all or no. And as we can see, significantly elevated postprandial triglycerides in diabetic patients. Similarly, even in non-obese young patients. In obese, much more in diabetic patients. So two causes, both obesity and diabetes causes increase in postprandial triglycerides. Seen even earlier than diabetes in the pre-diabetic stage, as this study published in DRCP suggests in 2008. So we concluded that in Indian patients, there is significant abnormality of PPTG metabolism, and these are seen in young as well as old, in obese as well as non-obese, much more striking in obese than non-obese, and also seen in newly detected and sometimes even in pre-diabetic individuals. So it's an entire spectrum of individuals, particularly with respect to glucose tolerance and obesity. You have postprandial triglycerides which are there all over, and it cannot be that they don't cause anything. In terms of cardiovascular risk, this was a study from Japan, which showed actually any TGs about 200 milligram per deciliter actually had more CIMT, a surrogate for CAD. We replicated this study and also looked at endothelial function and found clearly that persistent postprandial hypertriglyceridemia may result in a proatherogenic environment leading to atherosclerosis and macrovascular subjects in patients with macrovascular disease. And as you can see, there is increased postprandial endothelial function in the second and the third bars, which are both diabetic, the third being those with macrovascular disease. If you look at the right panel, the FMD, as we call it, or the endothelial dysfunction, actually worsens in the postprandial phase. even in those who have some dysfunction in the fasting state. And this is across the board, regardless of where you started, whether you are a diabetic or non-diabetic, endothelial dysfunction tends to worsen after meals, suggesting that this environment is far more important probably for a future cardiovascular event. And therefore, we actually said that repeated insults of high-fat meals in diabetic individuals may cause progressive postprandial endothelial function, because the way we looked at postprandial triglyceride was by giving them a high-fat challenge, fat tolerance tests as it is called. So if the same thing happens repeatedly, and we all know we consume more and more fat these days, and that could ultimately result in postprandial endothelial dysfunction, which is a harbinger of future CVD. Postprandial triglyceride responses and endothelial functions were also seen or examined by us in a pre-diabetic first-degree relatives with diabetes. And what did we find? It is much more in those with pre-diabetes compared to NGT, that's a group 2. Even more if they had a family history of diabetes, suggesting there could be a genetic component, and this is early. And we all know that pre-diabetes itself is a risk factor for CVD. So we said that all this shows that this may contribute to enhanced CV risk reported in pre-diabetic individuals. We also showed that there is significant postprandial oxidative stress in type 2 diabetic patients, particularly if they have macroangiopathy, that is CVD or other kinds of macroangiopathy. And this correlates very well with the postprandial triglyceride levels, suggesting that the mechanism by which this endothelial dysfunction occurs and maybe the predisposition to CVD occurs is probably by altering the oxidative stress in the postprandial phase. So it's all the postprandial metabolism probably which is more important. And even in terms of glucose, we all know that postprandial glucose is more associated with future cardiovascular risk. We're talking of glycemic variability and all those things, particularly because in the post-meal situation, even the glucose happens to be one of the triggers for a CAD compared to a fasting. Fasting is more related to microvascular disease. So conclusions were that all our studies indicate that Indian type 2 DM patients have significantly abnormal postprandial triglyceride metabolism, postprandial endothelial dysfunction, and postprandial oxidative stress. And these abnormalities were observed not only in established DM, but also newly detected type 2 diabetes and pre-diabetes. And therefore, PPTG could be a significant contributor to CV risk among Indians with glucose intolerance. So that was the conclusion of all these studies. And therefore, we thought that there is still a case for treating triglycerides, but probably we need to target the postprandial triglycerides to have the optimal benefit. After 20 years of my work now, this is an article, review article, which has just come up in January 2024 by quoting a lot of evidence. Now they say that we should start focusing on postprandial triglycerides and postprandial triglyceride metabolism in terms of cardiovascular risk, and we should stop thinking about the traditional LDL. And this is what we've been telling for the last 20 years, that the focus should be in the postprandial triglyceride. This review article actually now tells the same, and also gives some new information, recent research to support their case. So there is a need for all of us to shift from LDL-centric to triglyceride/PPTG and chylomicron-centric approach in cardiometabolic risk. Chylomicrons were never believed to be of any value. See, whenever I presented my data in several conferences, I was always told that VLDL is from the liver. It has nothing to do with oral intake. And chylomicrons are the ones which come after you eat, and they have nothing to do with cardiovascular risk. And this entire review article focuses on chylomicrons. And always I used to reply, and this is what is borne out by this review article, is even if it is the chylomicrons which increase, the same LPL is what they're competing for with the VLDL, which comes from the liver. And therefore, the VLDLs can rise. Chylomicrons are taken up more by LDL, by the LPL, or the lipoprotein lipase. So they are cleared faster. What remains is VLDL, and therefore they're not cleared properly. You get high VLDL, fine, but it's all elementary phenomena. It's all after a meal that is this happening. Okay, so statins have had such tremendous therapeutic success, as we all know. Over the last 3 decades, the field of atherosclerosis has become somewhat LDL-centric. We all know that. The relevance of triglycerides, particularly chylomicrons, in atherogenesis actually has been dismissed, which is what I was telling. Nonetheless, 50% of patients, and we again are aware of this, who take statins are still at risk of developing atherosclerotic cardiovascular disease and are unable to achieve their goal LDL-C levels also. So who are they? The residual risk is mediated to a large extent by triglyceride and triglyceride-rich lipoproteins. This fact has been recognized for long. It's not new. And what is new is chylomicrons. Chylomicron transport between 70 to 90 grams of dietary lipids each day, which means a huge chunk of what we take is being transported by chylomicrons. So it must have a role, or over 90% of the total lipids. This fact confirms the necessity for a shift in the field's focus, and to consider chylomicrons, which are the prime centers of postprandial triglycerides, and to say that they're critical, as we will see subsequently. And for this, we need to understand a bit, and recent research has actually focused our attention on this, the importance of LPL regulation, that means lipoprotein lipase regulation, for the partitioning of triglyceride-rich lipoproteins in the fast and the feds, how they are partitioned in the fasting state and the postprandial state. And is also supported by recent research. This is broadly the flux. Just to give you an idea before we move on, what we eat from the gut goes into chylomicrons, the triglycerides. It is eliminated by the lipoprotein lipase, either to the adipose tissue, primarily in the fed state or the postprandial state, and to the muscle in the fasting state where it is converted to energy. And that is regulated. And then, of course, from the adipose tissue, when you require, the fatty acids go to the liver, they make triglycerides, and even otherwise there is a hepatic output of triglycerides, which is the VLDL, which again is eliminated by the LPL. So broadly, this is a simplistic view of how the postprandial or even the fasting triglyceride metabolism takes place. That, if you understand that, the remaining is simple. So there are two concepts which I'll add at this stage. First is the intestinal de novo lipogenesis. We've heard about this DNL. It primarily used to occur in the liver and sometimes in the adipose tissue, where lipids were synthesized from carbohydrates that we eat. We all know that sucrose and even fructose particularly can get converted into lipids. So whether we take excess fat or whether we take excess carbohydrate, especially the free sugars and fructose, they become fat in the body. But this was thought to be in the liver and the adipose. Recent evidence over the last decade apparently has suggested that there is an important intestinal component and there is intestinal de novo lipogenesis. So even if you take a lot of fructose or a lot of sugars, you can have increased lipid synthesis within the intestinal cells. And that can contribute to the postprandial lipids, even from here, from the intestine. DNL, recent research suggests that these have an important role. And numerous studies actually have shown that in diabetic patients, there is increase in the DNL in the enterocytes. So that's why we have more of postprandial lipids, not only decreased clearance, but increased synthesis in the gut, which results in postprandial triglyceride increase. So an apparent paradox, as I said in the beginning, is a larger increase in postprandial TGs belong to VLDL, and I've already addressed that, why this is so. It's more because VLDL and chylomicrons compete for the same enzyme. And when you have more chylomicrons, and it has more affinity for that enzyme, it is cleared faster and more. What remains is VLDL, so you have a VLDL even though it's a postprandial event. And several other mechanisms which I'm not going into. This is the latest, and we already have a drug based on this. This is called the ANGPTL mechanisms or regulation of LPL. So LPL is closely regulated. The lipoprotein lipase, this is the enzyme actually. We have other lipases in the liver and the endothelium, but the most important is the LPL or the lipoprotein lipase, which clears the chylomicrons primarily, also the VLDL. And there are basically it's the ANGPTL angiopoietin-like substance, which is 3, which inhibits the LPL at the muscle level. We have the ANGPTL4, which inhibits LPL at the adipose level. And there is a third, which is the more important, ANGPTL8, which is secreted only by the liver only in the postprandial state, after meals. And what does it do? It shuts off, it promotes ANGPTL3, it promotes, and which more inhibition of LPL at the muscle level. So in the postprandial phase, triglycerides are not cleared into the muscle because of this. And it binds with the ANGPTL4, thereby improving, decreasing the inhibition of LPL at the adipose level, which means more enzymatic activity at the adipose level in the postprandial. So the critical thing is ANGPTL8, which directs or shifts the clearance of the lipids in the fasting state to the postprandial state, which is the lipids, where we want to store the lipids into the adipose tissue. So this is the key which we have to understand, and therefore, based on this, we have ANGPTL3 inhibitors for hypertriglyceridemia, which have been shown, demonstrated to cause significant triglyceride decrease recently. And however, long-term animal studies for cardiovascular benefit, of course, are awaited. But I believe that probably if we can find an ANGPTL8 agonist, that might be more critical. And there people are working on this, because that is clearly addressing the postprandial phase, and that must be, that in the future could be a drug that will address all the issues concerning triglycerides. With that background, so therefore, there is a clear place, and we are heading towards a situation where we will have drugs specifically addressing triglycerides, and that too in the postprandial phase in different manners. And in type 2 diabetes, I already told you, let's not go into depth. We have more of postprandial TG metabolism, and it's a strong predictor, as we have seen. The only problem, at least as of today, with PPTGs is difficulty to measure it. We do not know how to measure it. There, on the left are mentioned all the ways by which you can measure directly, indirectly, by looking at ApoB, non-HDL cholesterol, remnants, like proteins, ApoB48 measurements, or a fat challenge test. And look at TG at 4 hours, some people say about 200 is abnormal. All these are mentioned, but it doesn't very clearly or directly or without any pollution, it doesn't tell us about the postprandial TGs alone, and the VLDL and the chylomicrons. So pure chylomicrons can be assessed by newer assays, which is on the right, but it will take some time. So that is the limitation at the moment. With that, we quickly pass on for the next 5 minutes about a new area or a dimension. So about cardiovascular risk, we're finished and where we are. Is it useful to decrease PPTG even in the absence of diabetes, with the aim of reducing the risk of diabetes? That is the next question. We were only talking about cardiovascular risk reduction so far. Is there any evidence? We've shown you that this abnormality exists even in pre-diabetics, the red, between the diabetes and the NGT. We also found that there is a good correlation between TG area under the curve postprandially with HOMA-IR, so there is a good correlation with insulin resistance, but it was not clear whether insulin resistance leads to postprandial hypertriglyceridemia or vice versa. That was still to be established. And this clustering in hypertriglyceridemic patients also shows that there is a link. People showed in first-degree relatives, in NGT patients, first-degree relative diabetics also showed postprandial TG abnormalities. We showed on the right in pre-diabetics the same thing, that if you have a family history of diabetes, you have more postprandial hypertriglyceridemia, even if you're a pre-diabetic. And if you didn't have that family history, you are as good or as bad as an NGT. So there is some genetic component also which contributes to postprandial TGs, and probably it occurs much before diabetes. And even in NGTs, you find this abnormality. This is a study which we published in a Journal of Clinical Lipidology, which again shows that the fastings are same, but in those who have family history of diabetes, you have the postprandials which are high, both the peak postprandial TG as well as the area under the curve, the bottom graph. Both are high significantly, even in NGTs, if there is a family history of diabetes. And there's a good correlation with HOMA-IR only if you have a family history of diabetes, the right panel. The left, there is no good correlation. The R value here is far more, 0.35. This study from Japan showed that whether it is IFG or whether it is diabetes, there is a higher incidence in a 9-year follow-up if you had triglyceridemia or hypertriglyceridemia to begin with. So in a longitudinal study also, high TGs have been shown to be associated with glucose intolerance and even frank diabetes. With this background, we sought to once and for all settle this issue in an experimental study. And this is what was published in PLOS One, where we, in a diet-induced model of type 2 diabetes mellitus, for the first time we provided unequivocal evidence to suggest that if rats were given a chronic and recurrent high energy intake, the so-called sucrose model for diabetes, it results in immediate surges in lipids, particularly triglycerides, and later on leads to insulin resistance, prediabetes, and diabetes. And we showed very clearly in this study, I'm not showing that slide, the time course of events is such that immediately within the first week or two of this diet, the patients develop postprandial hypertriglyceridemia with no insulin resistance. It's about the 10th week or the 12th week that they start developing insulin resistance. By the 20th week, they start developing prediabetes, 20th to 24th week, suggesting that the chain of events, it is not insulin resistance causing the PPTG abnormalities, it is probably the reverse. And this was in a diet-induced model. So if you have a genetic predisposition, as we Indians do have, probably genes also add to this abnormality. And therefore, we looked at genes. And in this study, ICMR sponsored, we looked at 18 genes which were known to be associated with PPTGs, some of them also diabetogenic, and looked at their, both their polymorphisms and their expressions in the adipose tissue. We landed up with 3 most common genes which were affected, which we all know, the TCF7L2, the PPR gamma, and ADPOQ, all of which are known diabetogenic genes. And 2 other genes known to be associated with browning of fat, the UCP1 and the PRDM16. These were associated, and I'll talk briefly about how these are associated in the next 2 minutes. We found that there is good correlation, especially in those with the risk genotype of TCF7L2 with postprandial lipids, but not in the wild type. So there is a genetic association. Expression in adipose tissue much higher in the VAT, that is visceral adipose tissue of TCF7L2, which correlates with postprandial lipids. Same expression of PPR gamma is decreased because it's supposed to protect. So it decreases both in SAT and the VAT, correlates with post-PTG metabolism. So the diabetogenic nature is probably linked to the postprandial dysmetabolism. UCP1, PRDM, again, especially the UCP1, has decreased expression in the adipose tissue, PPDG, dysmetabolism associated, and also glucose intolerance. So there is a link, clear genetic link. So these studies actually go to prove that beyond the diet-induced model and beyond the diet that we take, a genetic predisposition, especially as demonstrated by us in Indians, probably shows that PPTG could be key determinants in predisposition to diabetes. So what does all this say? It all tells us that even with the goal of achieving a diabetes risk reduction, TG is a good and important and a critical target. And therefore, we should talk about TG reduction in terms of a holistic cardiometabolic risk, not just a CV risk. The last part of what I'm going to talk, energy metabolism. And this is where we'll talk about diabetes remission as well. This is how it has been hypothesized, what is called the lipocentric hypothesis for development of diabetes, where depending on whether your fat cells are hyperplastic or have or there is hyperplasia or there is increase in size, it depends. On that depends how your body responds to energy or high energy intake in the long run. Because if you cannot have hyperplasia, that means development of new cells because of some reason, and Indians are predisposed in that sense. All the genes that I showed you, the TCF7L2, PPR gamma, and all those, they're all closely linked to what we call adipogenesis, and Indians are known to have restricted adipogenesis. And therefore, if there is restricted adipogenesis, the fat cells do not multiply. So if you have more of energy and triglycerides coming into the adipose tissue, they cannot be trapped and accepted because more and more cells are required for that. So what happens is only the existing cells take them up, increase in size further, and we all know that that is a typical situation where adverse adipocytokines are secreted and you have all the inflammatory consequences in diabetes. As we can see from this slide, while Caucasians have a better way of hyperplasia, adipogenesis, they do not develop anything in the liver. They don't store fat in the liver because if fat doesn't get into the triglyceride or into the adipose tissue, it goes into ectopic tissues. We all know that. Whether it's the visceral adipose tissue, whether it is the viscera themselves, whether it is the liver, pancreas, heart, or elsewhere. And that is what causes all the problems. And Caucasians tend to do this late in the course of their natural history. South Asians, Indians, because of their phenotype, tend to do this much earlier. because we don't have a capacity to expand in terms of number of fat cells. And therefore, we, as the bottom, as we can see, and one of the important consequences of this is shown in dark, the increased triglycerides, which occurs particularly in the postprandial phase. With that, we come to the last 2 slides or 3 slides. We all know, and in the morning, it was referred to the direct trial for remission. The direct trial actually is based on, or the concept of diabetes remission is based on this hypothesis, which came out, I think, in 2012 or 13 from UK. The twin cycle hypothesis. It says that when you have positive energy balance, but that means when we keep on consuming more and do not exercise, what was talked about in the first session, and this occurs for long, there is a tendency to deposition of this in various tissues, the fat, and if you're insulin resistant, there is more hepatic fat, so you have more triglycerides, and it goes in, deposits in the pancreas, the beta cells become dysfunctional. And this was demonstrated to be a reversible phenomenon, which is the key thing. If you are somehow able to change or decrease the energy balance to a negative energy balance significantly, all these things would reverse, and the beta cells would regain their function, which earlier was not believed that could occur. And that's the basis of all the diabetes reversal programs these days, whether it is bariatric surgery or intense lifestyle measurement, whatever. But at the core of all this, you would see, is the VLDL in the postprandial phase. And what this doesn't mention, because the twin cycle hypothesis comes from Caucasian, not Indians or Asians, they've not talked about the upper arrow, the dark, which I have added on the basis of our own studies, that the positive energy balance doesn't, the triglycerides which are generated there from the chylomicrons don't get into the subcutaneous fat directly from there. Therefore, they are spilled over to the liver and the pancreas. So Indians are more susceptible to this pathway of, and there is, the silver lining is, so it is reversible. So there is a scope for reversal. Not pharmacological treatment, but intensive lifestyle treatment or bariatric surgery reverses this flow, decreases the triglycerides, and you have a reversal or remission in diabetes. So the last slide, the conclusion. So what did we talk in the last half an hour or so? Should we treat triglycerides? Yes. There's no question. Based on what I said, I hope you're all convinced. Should we treat fasting or postprandial triglycerides? I would think, based on my own experience and research, it should be the postprandial triglycerides, and we are missing the point there or missing the bus there. Is there a need to shift from LDL-centric approach to reduce CV risk and include PPTGs? Yes, certainly. Newer pharmacological approaches that target PPTGs by enhancing VAT clearance of chylomicrons and VLDL via LPL agents like ANG, LTP3 inhibitors are promising, as I've told you. Long-term benefits need to be looked at. Approaches that are aimed at substantially reducing energy intake. This is what we're talking about, reversal and remission, with very low caloric diets, low carbohydrates, and so on. With resultant decline in the PPTGs, because that's the center, that is what gets deposited in the ectopic tissues, can achieve remission in type 2 diabetes. So it is important, even from diabetes risk reduction, even from the angle of diabetes reversal. And recent research, therefore, has transformed our understanding about triglycerides and opened up newer vistas for its treatment. So I think at least the question that was posed in the beginning is answered. We should treat, we should find ways of treating the right triglycerides by the right methods in the future. So I acknowledge all my research team and the funding agencies for helping me with this research and development of this concept, which now world over people are now converging into, I hope. Thank you.